Good evening, guys. Just give me a second. Let me just turn down the fan a little bit. Background noise. Just a second. I have to talk a bit louder, and that takes a toll on my throat. All right. So, can you guys listen to me clearly, loud enough? Yeah. Okay. And this is section B, I think, right? Section B. Okay. All right, so last time we were talking about basically assessment of prognosis. Basically, we had started to talk about assessment of the elderly for these three, uh, aspects of their health prognosis, and then values and preferences of the elderly, and functionality, which basically is supposed to be independent functionality. I showed you basically these two tables, and uh, one this first table was about risk factors, prognostic, uh, you know um, mechanism, let's say, for the patients living at home. And this was the risk of mortality risk for the next 4 years. And in this next table, we talked about the prognostic factors and their associated risk points, and it helped us estimate basically the um, mortality rates or chances for mortality in the next 1 year. And this is for the patients who were discharged. And if you compare them both, so did we talk about this second table or not? We may and may not have. We did, okay. So if you look at the first table and the second one, and look at cancer. So this is for the patients who are living at home, right? And look at cancer. It does not say what cancer, which cancer. It does not say if it is metastasized or not, just cancer. If it's been diagnosed, score is 2 for patients living at home. And look at the cancer here. Let it be, there are two varieties of cancers here: cancer metastatic, cancer not metastatic. Even the not metastatic has three risk factors. See, and this is for patients who are discharged. So the point that we made yesterday about the prognosis for patients who are discharged as compared to prognosis of the patients who were living at home, the prognosis for the discharged ones is worse. So this is one very obvious thing in front of you. um, any cancer not metastatic, the score here for it is 3 compared to 2 in the patients living at home. And then we obviously had these two graphs as well. which kind of help us look at the median life expectancy. You've studied community medicine. I think you would be aware of what median is. This is not mean. I may have been actually using the word on average, on average. No, this is not average. This is median. So, what is a middle number exactly? Right? So, there's um, basically a single number represent which could represent uh, a set of numbers, right? So, there's means, modes, and medians, right? And mean calculation, how does it go? Add all the numbers basically in a set, divide them by the total number of numbers in the set, isn't it? Let's say there's 1 2 3. Add these three numbers divided by 3, because there's three numbers in this set. That will be average, or otherwise called as mean. Mode is the most commonly repeated number. Median is so it's not basically uh, more number frequently used. No, so median is a middle number, right? And mode is that more frequently number, right? So media, if you have a set, let's say there's a set of 3 4 5 numbers. Let's say the numbers in the set are 1 1 1 4 6 10. So in this basically set, the median is, which number would be the median in this set? This is the easiest question ever. 1 1 1 4 6 10. In this set, what will be the median? 1, exactly, because number 1 is repeated so many, 3 times, right? It's that number which is present more. So for that reason, the median, I would say, sorry, this is mode, more number repeated. Median is going to be, if you have a set of numbers, let's say, now this is going to be a bit tricky. If I just only speak it out. So let's just show, because it will have some impact on your understanding of what kind of data representation is there on the graph. Let's say there's these numbers. This is a set of numbers: 2, 20, 12, 4, 8. Right? This is a set. So first what we have to do is put them in order: 2, 4, 8, 12, 20. 1 2 3, yeah. So there's 5 numbers here. The median is this one. It's the middle number, right? 8. So you have to pick up the number in the middle. And so, which means, now if you look at these three varieties, mean, modes, and medians, the best representation of the set is done by means. And therefore, these modes and medians are not the best representations of the samples to begin with, right? Having said that, well, we have them, and there are these three alternative ways of representing a set. So when they basically have said that, let's say at 90 years of age, the life expectancy of women is, if this comes close to 50%, let's say 50% of the times at 90 years of age, the life expectancy is somewhere around 6 or 7 years for women, right? So this 90, sorry, 6 or 7 years, this figure is um, a median, right? And then they would have had so many 90 years of age females, and that would have created a set. And the number of years that each one of them would have lived would be basically the set. So some 6 years, some 8 years, some 7 years, some 10, 20, whatever the set would be. And then they have selected a median out of it. And that's how this graph has been plotted. So it's then again not the best figure to rely on, but it's, still better than nothing at all. So anyways, if you see these, types of datas, you should at least have some idea about it, because not all data is trustworthy, not all data is equally reliable, or not all data is equally accurate, right? Or not all types of data is the best form of data. So the last comment is the one that I'm making about these graphs, but they're still representing some truth from reality. Next, right, so um, we have to keep in mind, just like these individuals, elderlies from age 60 or 65, generally 60 and above, or more, better if it is 65 and above, just like any other age group, would have variability in their values and preferences. Now these values are not the values of their tests, right? Lab tests and all that. This is not what we're talking about. Those variations will also be there. That is true. But these values are the values that a person uh, has in their mm, opinions and thought processes. It's those values. And preferences exactly means what the word tells us. I mean, what do they prefer, right? So it means that uh, not all elderlies of the same age group would have the same preferences. It also means that a single elderly or old person that you might be seeing on regular basis, or are you seeing again, is necessary to be having, or holding the same value and having the same preference as the last time you saw them, right? So these values and preferences based on which you actually decide how to basically assess and manage and treat this elderly, right? Or the values based on which and preferences based on which the elderly may have actually already made a choice last time you saw them as a doctor. That may change next time they come in, right? So for that reason, if you keep it in mind that they can all be changing, not always, but they can change anytime. If you keep that in mind, you may float the idea again sometime about a test, about the treatment option. They may have actually experienced something which may change their mind as well, right? But generally, we have seen that elderlies prefer their own independence, their quality of life over prolonged life with deteriorated quality of life, right? So which means that they may not prefer, usually they don't prefer to live long, but to live better, right? It's this reason why a lot of patients of cancers do not opt for chemotherapies, because they don't want to go through the hell of experience a lot of the times, which cancer patients have to go through if they choose chemotherapy. Just losing hair is a trauma on its own, especially for females. Imagine a person who's been diagnosed with cancer and still in a work environment and socializing with friends and family and whatnot, and suddenly they know that, oh, next week they have to start chemotherapy, and they choose to do that, and there you go, hair falling, and rest of the things aside, there's a lot of other problems as well, but losing hair, right? And then it, even if they have not informed basically all their relatives and friends and colleagues and whatnot, it becomes, obvious, and then they have to actually talk about it even if they like it or not. So by choice, a lot of people don't. So uh, preferring uh, quality of life over prolonged life, right? This is generally a theme that has been observed in elderlies, in most elderlies, right? Because they've already lived a lot. So I mean, not too many people wish to live for the longest, right? Because especially when they are singles, when they are widowers, let's say, right? So because then they have to be living alone as well, and then with all these problems. So how can that be basically assessed? Only by talking to patient, by asking about these things. If you don't, this is another thing, that they may not express their preferences, right? And you have to ask them. If you ask, then they may give you the details or tell you about their preferences, right? And so usually it's them or their surrogate, who are surrogates. Surrogates are basically carers responsible for taking it. And then again, this happens in Western countries and better health systems where, they tax you a lot, a lot. We feel like we pay a lot of tax, but they tax you a lot over there. Up to 50% of earnings of people go to taxes. Doctors in US and UK literally pay 50% tax. If they earn $20,000 in US, a specialist earns close to 20,000 US dollars a month. 10 to 12,000 goes to taxes. Similarly, in UK as well. In UK, when a doctor's yearly earning touches close to £100,000, the tax rate is up close to 50%, 40, 45 plus. So they tax you a lot, and then they give you this, this facility that we are, all these systems and benefits and free healthcare and whatnot. That's how it happens. Or otherwise, insurances. Then again, for insurance as well, you have to pay every year. Nothing comes cheap, right? So um, surrogates are designated carers who are responsible for not only taking care, but at times making decisions. On behalf of the elderlies who are established to be not able to do that, legal decisions even at time, right? Like a guardian. So patients know their preferences best. So either we can talk with the patients, but if they don't have the capacity to do that, which also needs this assessment, we can talk to their surrogates if they are there. Right. And important point, if are you guys there listening? Yeah. How many students are there in the class today? 80. Good. Yesterday as well, there were 80. So we haven't lost any strength, at least in numbers. Right. So the next point is that uh, these elderlies, right, are going to mostly tell you about their preferences when you ask about it. And then they are going to make an informed expression of their preferences when you provide them with information. If you don't give them sufficient information about their condition, about the options available, about the benefits and harms that they could have to be then suffering and living with, minor or major, whatever, right? Unless they don't have that information, they're not going to actually be making a informed uh, expression for their preferences. So uh, provision of information, right? um, so then again, we mentioned this here as well, variability in values and preferences. So even having done all this in one of the sessions, when they go back, they sleep over it, right? Think about stuff, people, families, social life, you know, the bounties that they're living with, everything, and then change of opinion is still a possibility. So preferences can change over time as well, right? So that's not very uncommon to be happening. The function that we have already established what a function is. It is independent function, number one. The function is being able to do certain basic and then certain instrumental and then certain advanced functions independently. All of them have to be done independently, right? So we have already established what those basic everyday activities of daily life were. What were those? Can someone mention? Bathing, exactly. Dressing, not breathing, bathing. Eating, yes. Transferring, exactly. So bathing, dressing, eating, transferring, and using toilet, right? So these are the basic activities of life for everyone, that everyone if can do independently, that is perfect. But it's not just these. Then there are some another category of activities that we call as independent sorry instrumental activities of daily life. Previous abbreviation was ADL, now it is IADL, right? And these instrumental activities, I'll mention now, it's coming in the slides as well, are transportation, shopping, cooking, using a telephone, managing money. We talked about, that difficulty in managing finances, remember? Managing money, taking medications, house cleaning, laundry, right? These are instrumental activities of daily living or daily life. And basically, they are also required to assess a degree of function for the patient. Now, if you look at, uh, this point that we have already established, aging process takes a toll on the body and mind as well. So every elderly is going to have a decreasing capacity of and varying degrees of loss of function as their age increases, right? So that's an established fact. Some figures related with that: 25% of 65 years age individuals and 50%, half of 85 and above ages, need help for basic functions, which are that bathing, eating, toileting, transferring, that kind of stuff, right? So half of 85 years, that should make you, aware that when you see a, 85-year age patient, there's 50% chances that they have a problem with basic daily life activities, right? Now, Uh, we have already established that the preferences and values of a patient are what they are going to establish with the passage time, and they are going to possibly change them as well. They vary over time as well, and basically, uh, the choices that these individuals make are going to affect on the treatment of the patient as well, and it's going to limit our available options at times as well, right? And IADL, as I mentioned, right? So to screen a patient for these activities, daily life activities and instrumental daily life activities, you can ask for if the patient has lost weight significantly in recent times, if the patient has had falls anytime in the past, if the patient experiences incontinence, and you'll see, um, you know, this, for example, incontinence stuff. can lead on to affect a patient's life in a way that they may have altered their daily activities. And those activities basically would be, for example, could be any variety of activity, but for people whose you know changes in these functions are extremely subtle, very minute changes, so minute that it has not very significantly yet affected their functionality, but maybe has affected in a way that when they are out and about, it does become some of an issue. So for that, we then think about advanced, uh, you know, activities for daily life, and in that, some extra active, socializing and going out and about to community centers or parks, and for some, let's say, socializing kind of activity. And during that, if they are, facing a problem such as incontinence, which could at times become embarrassing as well, they may have stopped taking part in that activity. So, is that is also going to be among the questions that we'll ask them, that if they uh, the activities that they used to do before, are they still the same, or they have put on to some varieties of activities too. Yeah, there's variety of different types of urine incontinence as well, that we will, this is another huge topic. There's so many varieties of incontinence and urination, and there's so many variety of different reasons for that, and there's so many different varieties of treatments for each type of incontinence as well. That is also coming up. So, dip, ask about depressed mood. Ask about self-neglect, or self-neglect usually could actually be evident as well in the outlook of the patient too. Not taking much care of oneself and outlook, right? Dressing, cleanliness. Um, so, and then that would also have affected their socializing ability as well, right? Fear of safety. Now imagine an elderly who has a problem with their daily life, basic daily life activities. Imagine, um, let's say, when you ask about, are you afraid of actually um, doing stuff on your own? And the answer at times may be, yeah, when I'm really kind of concerned when I'm about to get off my bed, because at times I feel dizzy and can't maintain my balance, and I did have a fall once, so I really want to not let that happen again. So they're concerned about their safety. That's just one example, right? And then they're avoiding something, and then most of the time they may just choose to just stay in the bed. That gives rise to another problem, which is another topic, immobility, and that gives rise to so many other issues as well, right? So fear of safety. Also, talk about it. Raise the question, and you may get the information. Impairment of hearing, vision, cognition, mobility. Ask about these things as well, right? Later on in physical examination, you'll also basically see, when we physically examine them, uh, patients who are suspected of actually having a neurological deficit. So then, physical examination includes a neurological and mental exam as well. So, ask about hearing, vision, impairments, difficulties, cognition, higher thinking, decision making, and stuff like that, mobility, movement, motor skills. Um, ask about all that. And then, as I said, very minute, hard to pinpoint or identify type of changes, which usually happen in very early stages, right? They are not going to be identified by simply asking about the basic and instrumental activities of daily life. For them, as I mentioned, we'll be having to inquire about, talk about advanced activities of daily life, which, as I mentioned, include uh, activities which require some more effort, some more going out, some more social. For example, imagine um, there was an elderly who used to go to their community park, which is 2 blocks away, and they used to have a amazing time over there. They walked on the walking or the jogging path and saw so many people and children playing. Good, pleasant environment, such a relief from daily life and whatnot. What happened once they, felt dizzy for whatever reason and had a fall over there. And it was evening time, so there was not too many people, and they were too far from the patient. And it was embarrassing, and the patient could not get up, and that was it. So they stopped going there. So what happened? One little incident because of an episode of maybe dizziness for whatever reason it may happen. I'm not going there. Led on to them give up on or let them have a problem with their advanced activity of daily life. So this was something more than, or for example, if they used to actually do, or they actually do now, gardening as well, for example, right? So gardening also requires, sitting in certain postures, watering and cutting. It uses, then again, fingers holding, cutting tools and whatnot, right? Stitching clothes, stuff like that, right? So advanced activities when start to have issues, for example, such as I gave you example with the old, person who goes to the park, or otherwise incontinence in very early stages led on to give the person issue so much so that they have to go back and forth a lot of the time. They said, oh, what the hell, just, you know I just quit it, won't do it. Right? Bowling, it's a game, requires some skill as well, movement, posturing, right? And it takes a toll on your wrists as well, on your back, on your knees. If a normal person even plays bowling after a very long period of time of not having played it at all, believe me, you get a very bad ache and pain in your wrist and fingers, because these balls that we use for bowling are quite heavy, up to like, you know 5 kgs, 3 kgs, 2 kgs, 8 kgs. Different weight is there, right? So I hope you get the point what we mean to say here. We need to basically ask about those activities, advanced ones, to get information that what made them stop, because otherwise they may not mention it and it was in the past. And I mean, they are with you for some other complaint, and they might be in the early stages of developing some issues that you can pinpoint this way. And this is about what ADLs and IDLs are. So I have already mentioned that. I'll move on. This was general kind of approach and assessment for those three variety of things: preferences, values, prognosis, and functionality. Now it's something called as a frailty. It's also called as frailty syndrome, right? And this represents um, basically a certain degree of, I would say, weakness. So it's weakness which is lasting, and it's not just because of one reason, and it is not just weakness of energy, and it's not just weakness in muscles. It's a weakness, right, that is all over, in every system and part of the body, affecting everything overall: metabolism, physiological functions, functionality of all system and organs overall, right? So that then, and then leading on to uh, let's say exhaustion. This will be there as well: exhaustion or loss of physiologic reserves for whatever you may think of, metabolic nutrients and whatnot. So you can now imagine once a person in such a state of, I would say, exhaustion, metabolically, physiologically, physically, energy wise, nutrient wise, hope wise, right? Everything wise, and their whole body and system is being affected by it. They'll also be losing weight, and that is basically what we call as frailty, right? So it's a multi-system, multiple system dysregulation, and therefore, if we run tests for, and then which multi-systems, I would say, more importantly, liver, kidney, and to begin with, neurological system as well, right? And then other systems may also be start to be affected, but these ones may be the initial ones. So multiple system dysregulation leads on to that a lower state of energy and exhaustion. And whoever is suffering from frailty syndrome is definitely going to be. We list a lot of things as well that there will be high risk of those things too. But in general, they are at high risk of poor outcomes for anything, for everything. Any treatment, any surgery, generally prognosis as well for them is going, once they have got into this state of frailty, it's going to be worse, right? They will have weakness in general. They'll complain, will be, I feel weak all the time, right? And then their walking speed, their standing ability, for how long they can stand without sitting, and how far they can walk without being excessively tired and out of breath, how fast they can walk, and can they actually keep their gait normal while walking. All of this will be affected, right? They will have decreased physical activity, therefore, and ultimately weight loss, exhaustion, and will be always at a low state of energy, right? And as I said, they will be much at risk of now falls, which itself is a problem, hospitalizations, therefore, for numerous variety of reasons, and the functions that we have already talked about, daily life, instrumentals, and advanced decline of all the functions, and at much high risk, therefore, of death. These are all the, see, these are such basic things, but they are pointing fingers at danger, all of them. The more of them are present, the more of them are being affected, the higher the risk, right, for that person. And this is just some information that you can simply ask about and know about it simply by asking questions. If such a, such a patient obviously is not a very good candidate of surgery, but then again, if you have to do a surgery for a acute problem to save their life, that's another thing. But know that their expectations for the worst outcome of surgery can be there. It could be complication in the form of complications, in the form of patients, hemodynamic stability during the surgery as well. Obviously, yeah, uh, it is tried best to keep it in minute, but these are the people with, you know, loss of physiological reserve to begin with. So high risk patients. Now, when you start to actually do your internships after this semester, and you've cleared your licensing exams and whatnot, when you assist in surgical wards and attend the patients, remember frailty, right? And at times it's very obvious, and take care of such patients with even more efforts, right? So, because there's such problems could be arising from, then again, multiple different reasons and underlying problems. So therefore, the management them requires also multiple varieties of approaches. Multifactorial supportive approach has to be there, right? And most of all, it will require remobilization. Most of all, it will require uh, let's say if a patient has gone to that level of loss of energy that they are mostly not uh, doing their functionalities every day, and they are just not bothering to get up we need to first increase basically their motivation, number one. Number two, we have to actually improve their nutrition state. And number three, we have to improve their socializing chances, right? Introduce them with other age um, what age buddies, let's say, right? Somebody they can meet with on a regular basis, talk with, have a chat. They have to go to see some place that they can get together, right? Like a library maybe, or a park or something like that. And then along with this, obviously, resistance and strength gaining exercises to help improve their muscles. And these exercises can be done while lying down on the bed as well, right? So this is the same kind of advice basically that is given to the people who are very much immobile, right? So um, treatment basically is in that strength and resistance training. Um so best evidence comment here basically indicates that through research we have identified that there's nothing that works better for these frailty syndrome patients than strength and resistance training, as I just mentioned. What is resistance training? I mean, for example, move the leg at the knee joint, right? Ask the patient to extend the leg, and let's say a helper, a carer, or whoever, physiotherapist, a son, daughter, whoever it is, and they are actually pushing pressure on the leg and not letting it open. So generally slowly and steadily increasing the pressure and requiring more and more effort, but as the patient gains strength. But resistance training, right, extremely important. Next is the first actual topic, which is dementia. Now, I think you haven't studied this topic in any other subject so far, right? It's present. You haven't, right? Where are you guys? Psychiatry, you studied it. Okay. Okay. So it means you would know something about it. What about uh, its pathological features? Because in pathology, we didn't go that far. It's related with a few things. Dementia with few conditions. It's related with Alzheimer's disease. It's related with Parkinson's disease. It's related with frontotemporal, you know, lobar degeneration, and it's associated. These conditions have underlying accumulations of variety of different protein types, right? And dementia coexists a lot of the times with these conditions. Lewy body dementia is a term as well. Vascular dementia is a term as well. Dementia with Alzheimer's coexist most of the times, right? So, and then something called as delirium, right? So, I think because we didn't talk about basically the pathogenesis. That's time. Okay. So we'll be taking a break in like 3 minutes, but I would like to, um comment on these few pointers before actually we address dementia topic here. I would like to basically talk about different primary diseases associated with dementia, naming them, listing a few. I would like to therefore mention the type of misfolded non-degradable proteins associated with dementia associated conditions, which I named just now as well, right? And I would like to basically, therefore, comment a little bit on the pathogenesis of Alzheimer's disease, of Parkinson's disease, and of this frontotemporal lobar degeneration, which also this last one has a few subtypes to it as well, right? Because all of them can be coexisting with dementia, right? And dementia on its own, at times, basically, um, you know, it's not always that we are able to find out the underlying cause which is causing dementia. So dementia itself is a clinical syndrome which arises, possibly, as I said, most commonly along with the neurodegeneration that goes on in Alzheimer's, that happens in Alzheimer's disease, right? That's most common. But otherwise, these diseases which have neurodegeneration taking place in the brain, they also have dementia coexisting with them. And then, based on the underlying causes, for example, some the vascular dementia that has ischemia, for example, or cerebrovascular accidents, let's say strokes, leading on to cause you know um, necrosis, damage in the brain. But that is a focal lesion at one place where this has happened, a vascular lesion develops. But the point is that the brain damage takes place, and as Sarvat 169 has just mentioned, that it is memory loss. So with dementia, memory loss is a problem, and it's short-term memory loss, mostly in the beginning. And if this is what you can keep in mind, so the focal lesions, if they are affecting the brain because of the conditions which only affect a limited part of the brain, and memory is being affected, in most of the cases it is the temporal lobe, hippocampus area associated with memory, right? And therefore other conditions like Alzheimer disease or other ones which do not have focal lesions but rather have more generalized multiple lesions developing in the brain, involving also the memory centers, can also have dementia associated with them. So I'd like to, briefly comment on a few things here related with this, so that because I didn't talk about these topics in pathology, so you get a little insight into that, and then we'll start talking about it here. Let's have a break here, and it's 10 minutes, and after the break, we'll discuss this. Yeah, guys, I'm back. The break is over. Please confirm that you can listen to me clearly and loud enough. Yeah, okay. So, what I'll do is I will open up a Word document and we'll start to put things in context here. Uh, right. So, first of all, talking about the pathogenesis, because I mentioned Alzheimer disease, Parkinson's disease, and uh, frontotemporal lobar degeneration. These three are the most associated with dementia. It coexists with them, right? So for that reason, it's important to know what the difference is as far as basically the pathological accumulations are concerned and the reason for their accumulations. So Alzheimer's, right? Now this is obviously um, neurodegenerative condition. What's up? Right, and it has, um, if you remember, we talked about amyloidosis in pathology, remember? And in amyloidosis we talked about some precursor varieties of precursor proteins, and we mentioned that those precursor proteins, for numerous reasons, because of mutations or otherwise, because of genetic problems acquired or inherited, lead on to be producing certain form of proteins which become non-degradable. Exactly. So we have beta amyloids, written as a beta. Exactly. So a, I'll just write it down because obviously I can't put the symbol there. So we have beta amyloids that are going to be accumulated in the brain, right, over the time. And basically, we have this amyloid precursor protein, right, APP, which is supposed to be converted by enzymes into this beta amyloids, right? The precursor, the amyloid precursor proteins, APPs. There are a variety of different enzymes which can do that, and in that we have gamma secretase and uh, alpha secretase, two varieties of enzymes which are capable of degrading this apolipoproteins, right? And because of improper mutated activation of this apolipoproteins, it's converted basically into those beta amyloids which are non-degradable, and they start to be deposited and non-degradable, right? And if you could remember, these were not those reactionary proteins like prions. Although you'll see that even in prion protein disease of whichever type, you also have this issue of dementia to be associated with them, right? Because they are, reactionary and convert other proteins into those non-degradable misfolded proteins too. But these ones are not just reactionary, they just accumulate, they are non-degradable, and they interfere in the functionality of neurons. Now in different conditions, what happens in this Alzheimer disease, this is basically the type of non-degradable protein which accumulates. In other ones later on, which I list, you'll see that they are accumulated generally basically within the brain, uh, within the neurons, or in and around the neurons, uh, or in synaptic spaces, right? So this is generally the concepts of basically these neurodegenerative most conditions with which have accumulations of these non-degradable proteins in them, and they interfere with the functionality basically. Right. So, point important after that. Remember, we mentioned this. Um, Not apolipoprotein. I've been using APP is not the abbreviation of apolipoprotein. It is amyloid precursor protein. Let me write it here. Amyloid APP for amyloid precursor protein. That is the one which is converted basically into this one. Right. So we this gene for APP protein is located on which chromosome? Any idea? If you remember that, you can then connect this information with some other conditions which increase the risk of having Alzheimer's disease. So, gene for APP is located on 21st chromosome 21. And then if you think about trisomy 21, remember Down syndrome, right? So, Down syndrome patients have more the chances of Alzheimer's disease as well, therefore, for this very same reason, because they have an extra chromosome, the same type with us, likely the same gene, and more the chances of its conversion into beta amyloid. Right, this is one thing. And now, apart from that, some people actually have a genetic risk factor other than just mutation in the enzymes causing conversion of APP to A beta beta amyloids, right? So here enzymes and their mutations were the problem. Other than that, we have another chance, special protein, special genes called as basically APOE4, right? So it's an abbreviation for lipoprotein epsilon 4, right? Metal retardation common, yeah. So apolipoprotein epsilon 4 is the name for basically the genes, and the point is that its presence is not the guarantee for Alzheimer's disease, right? But it has been associated with a lot of the cases of Alzheimer's disease, and it's been the case that more the number of alleles of APOE4 gene to be present, and the chances are more for Alzheimer's to be taking place. But at the very same time, Alzheimer's still has been seen to be happening in patients without the presence of this APOE4 gene. So we can't actually quantify how likely it is to develop Alzheimer's with it or without it, but because it develops with it as well as without it, so it's worthy to mention that it's that kind of a dilemma associated with it. All right. Now, how exactly basically this gene leads on to convert same APP protein, right, amyloid precursor protein, to beta amyloids is totally unknown. We have no clue how does that happen, but it's been seen to be happening and taking place. Right. So, it's basically the depositions of beta amyloids within the neurons as well as in the synaptic places that number one interferes with the neuronal functions, conductions, transductions, whatever you would like to include here, and um, depositions also responsible for inducing inflammation, which then cause further cause of damage to the brain, and it's not happening specifically at any one location in the brain, right? um, Other than that, we have one more thing, which is not very then again common to be happening in Alzheimer's disease patients, but has been seen to be taking place, which is this beta amyloid proteins also, uh, beta A or A beta, let's write that A beta, also leads on to hyperphosphorylation of, if you can remember, microtubules within the neurons, called as tau proteins, right? So this beta amyloid protein also has a possibility of hyperphosphorylation of tau microtubules, and therefore we have this non-degradable proteins accumulation possibly to be taking place, right? And then when they accumulate, they lead on to form basically what we call as these proteinaceous tangles. And remember that therefore now majorly Alzheimer's disease has uh, this types of accumulations, which is tau protein and beta amyloid. These are two variant types of proteinaceous non-degradable accumulations that take place in uh, Alzheimer's disease, inside the neurons and outside the neurons in the synaptic spaces, right? And are source of inflammation to be taking place and causing further damage to the neurons, right? And the this this frontotemporal, what you call it, lobar, no, frontotemporal, yeah, lobar degeneration one, which has further subclasses, that also has tau protein depositions, but the tau protein formation exactly and its structure may not be the same as the tau proteins in Alzheimer's, right? And we basically also have Parkinson's disease, right? So this is another major condition that has dementia associated with it. And Parkinson's disease has basically, um, depositions of these alpha synuclein, right? And therefore, um, accumulations, uh, leading on to be called as later on possibly Levy bodies. And they Levy bodies, let me just briefly show you what Levy bodies might be, because there's something also, another variety of this stuff is also, when accumulated within the neurons, is called as pick cells or pick bodies. So let's, Levy bodies, what are they, how do they look like? Levy body dementia is also a type of dementia. Where is it? There is it. See, so this round accumulation basically is not a very good image, but let's say if this could be a whole Levy body. Let's see a neuron with the Levy body in it. So yeah, this could be the neuron, its nucleus, and the Levy body, proteinaceous accumulation, right? So Levy bodies may look like this, and those pick bodies or pick cells, which basically uh, are also some things which accumulate within the neurons, uh, are basically associated with one type of frontal temporal lobar degeneration, right? So a subtype of frontal temporal lobar degeneration called as pick disease has pick bodies, which to an extent also looks quite similar. They are round circular accumulations as well within the nerves. They are all formed. Once they are formed, that condition is called as pick disease, right? So That's what you have to keep in mind. The varieties of accumulations in Parkinson's disease, Alzheimer's disease, and um now in frontal temporal, let's come to this frontal temporal lobar degeneration, right? Um, this is also a progressive, uh, neurodegenerative condition, as the name suggests, frontal and temporal. So it affects these two parts of the brain, these lobes. And temporal lobe, has hippocampus. And once, involvement of hippocampus and degeneration of that area is going to be involved, memory does become, an important um, function to be affected, right? And therefore dementia. In case of Alzheimer's, there's no specific location, but generally keeps on happening, even likely at that memory spot, right? So, variation in the presentations of frontal temporal lobar degeneration. Let me go back, right? Are there. So, some varieties of frontal temporal lobar degenerations affect more on language, and other variants of frontal temporal lobar degeneration affect more on memory function, right? So, which one of the presentation is more prominently taking place? Uh, Linguistic one or the memory one helps us differentiate one type from the other, right? So, um, I think let's now go back to the content of dementia, now that you have a little bit of background into what variety of other conditions are there and what is the problem with them. As far as the pathogenesis is concerned, accumulation of variety of different proteins, neurodegeneration, its interference with the functionality of neurons, and not proper, messagings and transports through the synaptic places, and inflammatory damages, right? And so dementia is bound to be coexisting with these conditions, but keeping in mind the locations of deposition. So some other presentations of involvement of cognition impairments, motor skills to be affected, linguistic skills to be affected, those variety of presentation is also going to be there. And you'll see some more tables coming up for varieties of dementia and some comparison between them as well. So dementia itself is an acquired, persistent, yeah, aphasia as well, and there's quite a few other things also coming up. It's acquired, persistent, and progressive clinical syndrome. So it does keep on getting worse, right? And once developed, it may not completely improve, right? Because at the back end of it, there's a problem with interference, at least, or damage and degeneration of the neurons involved in it, right? So it therefore as coexist with quite a lot of other conditions affecting other parts of brains as well. So it's not just, we have to keep in mind, because both of these conditions, dementia and delirium, also coexist a lot of the times. But the difference between these two is dementia is memory focused. The problem with dementia is that it affects memory, and it is progressive, persistent. It does not come and go, right? Whereas delirium is going to be an acute, phasic or episodic problem, right? And it's not related with memory, rather attention, uh, and therefore orientation. It's more towards confusion state, because of uh, inability to pay attention to stuff, and therefore arising confusion out of that state. And it's episodes, and it comes and goes. The person is kind of disoriented, confused, lost for some time, and then when the episode is over, they're perfectly fine. So delirium is that. And then there's a lot of drugs that also are associated with causing delirium and dementias too. So you'll see that too. right? So this difference of memory and attention and orientation um problems should be kept in mind. Are you guys there listening? Okay. So in dementia, major thing to be compromised in memory, and once it has started to be compromised, it will remain that way, and it could and does usually, because it's progressive, get worse. Right? Depending on underlying condition, degree of its worsening may be variable. Um, now, a lot of the times, what has been observed in this age group, especially remember age-related changes and you know age-related degeneration of tissues, atrophies that happen, right? In different parts of the body, even in muscles takes place, happens to the nervous system as well as we keep on aging. So memory being affected, there's another thing very interesting coming up, uh, not related with age but rather something else. So what I want to say here is that generally age or process of aging can also lead on to make a person's ability to process things a bit slower, and that may interfere with recalling something from memory bank as well, right? So that may not be dementia, right? That is something else. That is just aging and slowing down of all the processes basically in the body, right? And it's a consequence of being old, and it's much more common, not just dementia. And we have basically then again tools and instruments to actually assess a person if they have dementia likely or not. So usually what we have seen is that these people have, along with memory loss, they have at least one more cognitive domain to be affected. So there's some other cognitive deficiency as well, usually including aphasia, apraxia, agnosia, or impaired executive function. So what entails each one of them, right? Aphasia, it basically stands for um, inability to find the what I'm doing right now, finding, thinking of words to make a sentence and communicate with you, right? So inability to formulate a linguistic uh, sentence and conversation, right? Loss of words, and basically it's a temporal lobe, which is usually found to be associated with aphasia, temporal lobe degeneration. With apraxia, we have motor disorder, and people find it difficult in motor planning, right? So whatever task that requires motor activity, right, movement, planning that goes in the head for that activity is basically affected, right? So for example, when you want to tie shoelaces, there is certain specific ways in which fingers have to be moved and laces have to be held to tie a knot in the laces, right? So planning for the to carry out those movements is lacking, right? And usually is the posterior parietal part of the cortical brain that is involved, and more specifically the corpus callosum area, which may be involved in degeneration and damages, right? Next we have agnosia. Agnosia basically is altered ability to make sense of the sensory input that our brain is getting, right? So there's a lot of sensory information, eyes, sound, ear, taste, whatnot, right? Sight. and so many others. So um, the sensory input that is coming from these senses is basically being translated as well. So not being able to make sense of those sensory inputs leads on to um, a state of being which we are calling as agnosia, right? And the part of the brain which is supposed to be affected with agnosia is occipitotemporal lobe area, right? So, and other than that, now we also have executive functions. So, what are executive functions? Then again, with planning and making decisions. For example, the other day, I had this. I was watching a video. There was a YouTube blogger who was traveling here and there, and she said that for some people, it's she was just commenting on this, just by the way, that she was traveling in a van. She customized it and traveling in a van in UK and whatnot. Eva Zubek, I think, is the name for her. And she was talking about her clothes that she buys. So she wears very simple clothes, and they were yeah, Eva, exactly. So she wears, a T-shirt of same plain colors, and then a simple trouser, and sometimes you know, just a couple of types of checkered shirts to put on top of she shirt. So the reason she actually gave it to have such simple choice for her clothing was that I just find it extremely stressful and um, you know uh, traumatizing experience to have to choose between my clothes what I have to wear in the morning. And she was like, most of the people it's not that much of an issue, but I just cannot make a decision what to wear. Might not be anything at all. It could be a basic problem with executive task. And believe me, I mean, she is traveling all over the world, and that's very nice, travel vlogger. But the problem is that the kind of balance that you see in a person's life, you know, that balance is completely lacking from hers. And from the story that I've followed her so far, she has had problem with the relationships as well, just because of that she cannot just settle in one place and have a usual normal life like others. So I see it as a underlying problem that she has with executive decision making problem. So it's something that just popped up in my head, right? So planning and decision making issues, and the error correction ability. If you make some errors in your let's say decision making or otherwise planning, so correcting them, or in planning off the motor activities as well. So those corrective uh, what do you call them, initiations are also difficult to be made if there's a problem with executive category of functions, right? So such varieties of problems make, usually they do coexist, at least one of them, with the memory deficit that comes with dementia. Okay, look at this image, and I've put it there to make those things visually available in front of you to maybe help you remember the dementia issue. Memory being the most important, and the rest being those cognitive issues: language, judgment, thinking, all right, perception, reasoning, attention, concentration. This represents delirium. Rest, this is dementia problem plus any one of these cognitive problems. And because dementia usually coexists with delirium, that attention or concentration deficit represents episodic acute attention and concentration problems represents delirium, and they do coexist as well. So you see dementia coexists with so many things, right? And this is a very interesting correlation that I wanted to share. I came across this one. So they did a study in, I think it's from UK, and it's published in Oxford University Press, Journal of Epidemiology last year, I believe. And they found out that there's a relation in females specifically, and females are more affected by dementia, and I think so. So they found out that there's a very strong relationship uh, between atrophic decrease in size of hippocampus and increase in size of waist. So, which means that in females, especially aged 50 and above, they collected the samples of such females and observed these two things: their waist sizes, which means how fat they were, overweight and whatnot, and through, obviously imaging studies, the size of their hippocampus. And they realized the more the waist above 34 inches in females of age 50 and above, the smaller their hippocampuses were getting. And that meant memory issues, dementia, and others. So, this is one of those things which may cause dementia, but may not have underlying neurodegenerative conditions associated with it. Does that make sense? How exactly does that fat cause release of free radicals and cause neuro? Yeah. So uh, they did not mention. I've not completely read it, but I think they did not literally mention degeneration of neurological tissue, but they did mention atrophic changes in this what do you call it, hippocampus, right? So I've actually included the link here as well. You can click on it holding control button when you get the slides and go through the article as well, right? And there is some comparison between different types of dementia. Now, as I mentioned, Alzheimer's disease, of all dementia, sorry, dementia associated with Alzheimer's disease, 50 to 80% of dementia is associated with Alzheimer's disease, right? And in this one, what you have is generalized atrophy of the brain, beta amyloid plaques, and they form these neurofibrillary tangles. And there was tau protein as well, secondary varieties of non-degradative proteins. And then there is a vascular dementia, and as I mentioned, the name speaks up for itself. In vascular dementia, the problem is vascular accidents, signs of vascular diseases, ischemic or as it's called CVA, rupture of blood vessels in the brain, leading on to then brain damage, right? And therefore, if it leads on to affect the memory parts of the brain, outcome dementia, right? So strokes, and pathologically the findings could be, if it's ischemia, lacunar infarcts, right? White matter lesions, and vulnerable to cerebrovascular events as well. So it could be hemorrhagic, uh, you know, hematomas and hemorrhagic accumulations and necrosis as well. Then we have Lewy body dementia, in which there are presence of Lewy bodies. And I've shown you what Lewy bodies are. 10 to 25% of dementia are that. And then again, look at that. It also generally affects the brain. And these Lewy bodies are found basically in the cortical area and midbrain areas within the neurons. And frontotemporal uh, lobar degeneration, which has many subtypes, including, remember, pick bodies, pick cells that I mentioned. And the area, the name suggests the part of the brain, fronto and temporal atrophy takes place, right? And their onsets sometimes are a little bit different from each other. So you can look at this table. It's quite informative, and the signs and symptoms could be a little bit different from each other depending on the location that they affect. Right? There is another image that you can look for because other than those conditions that we just talked about, right, which could be the underlying causes and associated factors for causing dementia, could be all of these as well, right? So if the patient has a problem basically with the now eyes and ears, um, so let's first just mention dementia. They've used all the letters here for you to pay attention to: drug and alcohol, eyes and ears, metabolic endocrine disorders, emotional disorders, neurologic disorders, tumors and trauma, infection, arteriovascular diseases, right? So it is to draw your attention towards all of these. Use this mnemonic to remember all this. Why? Dementia, a lot of the times, will be presenting with delirium. Delirium, as we just mentioned in the previous image, was uh, this attention and concentration problem, leading on to that confused state. So that delirium, confused state of being not able to concentrate much can be happening because of a lot of reasons, but due to sensory impairment, especially in eyes and ears as well, right? So elderly, especially, who are at who have fear of being injured or falling down, uh, get nervous very easily, are concerned, are weak, are fragile, remember. So for them to be confused, it's quite easy. Not always because they have dementia or delirium or any other neurodegenerative disease, just because that they are they just have that profile. uh, you know they're so vulnerable. That's why we actually call them vulnerable adults, right? So that's why eyes and ears are there. Otherwise, all these varieties of things listed here could be the underlying reasons to affect one thing or the other. Not exactly going to the details how and where and through what processes, but can lead on to cause dementia as well. So ask about them. Do you have any problem with these ones, right? And then whatever variety of problems that they may have, we have to then alter them and see, modify them and see if their dementia improves or not. So when memory and cognitive effects are sufficiently declined, uh, only then they start to affect the work and social life and routine activities of the individuals. Otherwise, usually in initial very mild forms, it does not affect the social life or otherwise daily routine of the person. Prevalence, you see, doubling every 5 years in the population of 85 and plus ages, right? That's a lot. 30 to 50% of dementia patients are 85 years and above. And you saw 50 to 80%, that two-thirds of cases of Alzheimer's uh, lead on to cause dementia in the United States of America. And the rest are vascular dementia, dementia with Lewy bodies, or the frontal one, as we talked about. Depression also commonly coexists in early stages, especially, right? And delirium also a lot of the times coexisting. So this is an acute episodic state of inattention and confusion, right, which could coexist with dementia. Now, how to screen for cognitive impairment? We have already talked about what are those varieties of cognitive plus one cognitive function, remember, that could be affected. So to screen for cognitive impairment, what can we do? Number one, we can do genetic testing for that lipoprotein epsilon 4, right? And gene. And if it's, then again, keep that point in mind that even if it is present, it's just a risk factor that maybe this person is genetically predisposed to getting dementia. If it is not present, does not mean that the patient must not have dementia. It's just that, right? And other than that, we have certain variety of, then again, those tools and instruments that can be used to assess a patient's cognitive ability. So one of the tests is a mini cog test, in which we check the patient for, and I have a sample of it. I'll upload this. I've basically uploaded already the books, and so now video lectures need to be uploaded, and uh, these, documents that I'm gathering. So I'll be creating that Word document with the links today and sending to the CRs. So this is the mini cog test for assessing the cognition of the. Have you seen this? If you studied dementia, have you then come across this one or not? No. So this is very simple, very basic, crucial, important test. Right now, it has three steps to it. Number one, we from any of these columns pick the three words under them, like this first column, banana, sunrise, chair, or any one of them, right? Any column, pick one column, and then these are the three words that you are going to use, or these are the three words that you're going to use. So what you do is you tell the patient, it's not a memory test, remember, it's a cognition test. So you have to tell the patient that I'm going to say these three words, right? And I want you to repeat these three words after, once you would have spoken them, you want the patient to repeat those three words back to you. That's first point. And secondly, you need to tell them that they should remember these three words as well, whichever three words you may be using. Okay. So, first step, if they repeat those three words right after you've said them correctly, that's how we're going to score them. And then we'll move to the second task. Remember, we have also asked them to memorize those three words. This we'll do after the second task. We'll ask about these three words again, but after the second task. The second task is clock drawing. Now, how do you ask the patient to draw a clock? A circle is already supposed to be printed on this. You can literally print this out and use it. So a circle is already drawn, and you give it to the patient, and then you'll ask the patient to step by step do stuff. First, you'll ask the patient to put the numbers in their right places. Okay, numbers of the hour. So 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right, in their correct places. Once they're done with that, and remember, overall this task I think should be finishing within 3 minutes, this one, block drawing task. So the second, once they've done that, then you ask them to put the arms of the clock at 10 past 11, right? So put in all of the numbers where they go first, and then set the hands to 10 past 11. What does that mean? It means obviously the small hand goes to 11, and the longer one should be at 10, 10 past 11, isn't it? So it requires thinking, judgment, isn't it? So uh, the point is that the circle needs to be pre-drawn, and the complete time, this task of writing the numbers in correct places and drawing the hands should be finished within 3 minutes, right? And if it's not complete within 3 minutes, the time is over and the patient is still working on it, you move on to the step three, which is step three. You ask them to recall the three words you stated in the step one, right? And then the scoring. So first of all, if they repeated the three words the first time you spoke them out, you give them numbers 1 to 3, 0 to 3. One correct, one number, two correct, two numbers, three correct, three numbers. And for drawing the clock, normal clock, 2 points, right? And if the what is a normal clock? Numbers were placed in the correct sequence and approximately at correct positions, right? So sequence of numbers should be correct, and their placement approximately should be correct, not precise, but roughly where they're supposed to be. right? And there shouldn't be any duplication or missing of the numbers, obviously. Then the pointing of the hands, the short ones and the long ones should be in the correct position, making it look like 10 past 11, right? So if they've done that, you score them 0 out of 2. There were two steps, numbers and hands, so 2 points if both were done correctly. If the patient simply can't do that, it will happen if they have a problem with cognition, so 0 mark for that then, right? And then the total score. Usually a cutoff point of less than 3 score in this one should mean total score that the patient has a dementia. But because there can be a little bit of margin of error here and there, so instead of just 3, it's better to take less than 4 score to be marking the patient as a dementia patient. So this is a mini cog test. This is the document that I will be uploading as well into the online folder. And then there is a this one as well, Montreal Cognitive Assessment as well, MOCA, otherwise called as. This is a little bit more enhanced cognition test. These are the tools and instruments, that I've been talking about that are used here and there. So first test, second test for naming them. This is to get the sequence. Number one, letter A. Number two, you say what would be the thing, right? The second letter. Then number three, and the third letter. Number four, the fourth letter, like that. So they have to do this. Obviously, you don't tell them that. Then to draw a cube and draw a clock, 10 past 11, same thing. Naming these animals and memory. So you can read through it. There's like 30. No, this is not that 30 version test. The score is 30. Yeah. The score for all of these questions is 30, and you score which anything less than 26. Sorry, greater than 26 is normal, and less than 26 may actually be taken as a you know a problem with memory and cognition overall. So uh, that will also be uploaded. Okay, Montreal Cognitive Assessment, 30 points, and it should not take anything more than 10 minutes as well. So there's time limitations to completion of these tasks as well. Right, next there is screening for decision making capacity, but the time is over. Let's quickly run over it. These obviously elderlies do have decision making challenges. If there's going to be a problem with them, the thing is that we have to give them options about what to do and what not to do, what benefits and drawbacks are there for their tests and treatments and all that stuff. So can they even comprehend all that, and do they have the capacity basically to entertain that information and make their informed choices, which then again are correct ones or not, right? And are they making it actually after understanding them or not? So for assessment, we have 5 elements to check. It's their ability to express choice, right? Are they actually just following your lead, or they are making their own choice? So testing for that. Other than that, we have to assess if they actually understand that when you are telling them about the risks and benefits, are they actually inquiring about any other further alternatives available or not? And so from very first, when you start asking about these things to analyze, you have to also observe if they are leaning toward a certain choice of taking a certain test or a treatment option or not. If they are leaning, then you have to see if they are consistently leaning toward that choice or not, right? So because if they're leaning toward choice, they would have a set of mind, and after analysis they would be making that opinion. So comprehension of a problem and its consequences, along with ability to reason, discuss, there should be a discussion, and then consistency of a choice, right? So this represents an actual activity of higher function, isn't it? reasoning, choice making, information analysis, ability to comprehend all that, and then consistently leaning toward one choice. If it's not all that, it means they may not even have a capacity to make that decision. So in that case, then next of kins or carers or surrogates or legal surrogates, otherwise for legal choices making, they would have to be actually taken. So let's, I think, stop here, and we'll talk about the other content in the next class. I hope everything is clear so far. It's been a bit drier type of content, but it's going to become more less theoretical and more, actual practical toward treatments and let's say management kind of content. So these were the topics as such, require more of a understanding theoretical basis assessments. But in the next topics, it's going to be more of a practically medical approaches. That's all. Thank you very much. Take care and bye bye. Thanks all.